Dear chairs, dear audience, thank you to let me introduce my PhD thesis about the novel treatment of advanced urothelial cancer. I'm Mohammed Altenni. I'm a urologist, and my mission to provide outstanding clinical treatment for patients with advanced urothelial cancer in a strong academic environment. My mission to serve bladder cancer patients with compassion, professionalism, integrity, and excellence. According to this, I have two ongoing specific goals, both of them about the same disease, which is advanced urothelial cancer with a different kind of novel treatment. First project about enfortumab vedotin, and the second project about immune checkpoint inhibitors. Let me start with my first project, which is identifying patients who would benefit from enfortumab vedotin in advanced urothelial cancer. A little bit about the background here, that we know that urothelial cancer is a very aggressive disease. We have more than 500,000 new cases per year worldwide, and nearly half of them will die. The 5-year survival from metastatic urothelial cancer is around 7%. And those patients with advanced urothelial cancer are undertreated, especially in the third-line setting. As we can see here in the first-line setting, less than 60% will receive first-line treatment, which is chemotherapy, and less than 10% will receive the third-line therapy. Enfortumab vedotin is a new third-line therapy for advanced urothelial cancer according to the EV301 randomized control trial, because the superiority than chemotherapy in overall survival and objective response rate. Unfortunately, in a randomized trial, we can say that those patients have a strict eligibility criteria, and in the real world, those patients are less selected. And it's still unknown which patient will benefit more from the treatment. So our aim here to identifying patients who would benefit more from enfortumab vedotin. Our clinical question: how do different clinical parameters impact the outcomes of EV-treated advanced urothelial cancer patients? We use a PECO framework, and our population patient with advanced urothelial cancer treated with EV. And we are comparing different patient characteristics and our outcomes over survival, progression-free survival, and radiographic response. We hypothesize that enfortumab vedotin provides greater benefit to advanced urothelial cancer patients with specific characteristics. We conducted our search key in 3 main databases. We used the search key you can see below, and we got more than 1,600 articles, and after the selection procedure, we ended up with 23 articles. So here I would like to show you my first forest plot, which is an overview for the proportion of objective response rate between prospective studies in the upper part of the forest plot and retrospective studies in the lower part. As we can see here, that the proportion of response in the upper part is 0.44. That means 44% of patients will respond to this novel treatment. And in the retrospective studies, we have a little bit higher response rate. My second project, we are comparing, my second forest plot, we are comparing the objective response rate between patients with the prior response to previous therapy and with those who not responded to previous immune checkpoint therapy. We have 6 studies here, and we measured the odds ratio. And as you can see here, the odds ratio between the two groups, 1.51, which means that patients who previously responded to immune checkpoint inhibitor have a higher response rate to enfortumab vedotin than patients who not responded. The third figure about we are comparing our 3 main outcomes, overall survival and progression-free survival between patients with favorable ECOG status and with those with unfavorable ECOG status. And our results here is consistently statistically significant and clinically relevant that patients with favorable ECOG status have a higher response rate and a higher hazard to survival also. This is our fourth figure. We are comparing the objective response rate, overall survival, and progression-free survival between patients with pure urothelial histology and with patient with pure urothelial histology with any variant histology. And as we can see here, regarding the objective response rate, our results not statistically significant, neither clinically relevant. It's also for overall survival, but for progression-free survival, we found that those patients with a pure urothelial cancer have a lower hazard ratio to progress. The strength of our study that this is the first systematic review and meta-analysis assessing the prognostic and predictive clinical and molecular factors of enfortumab vedotin sensitivity. And we assessed a patient-level data from 2 large retrospective studies also. We have limitation that we use only univariable analysis, and patient-level data are available for all study, and we use also retrospective studies. So my conclusion that patients with session parameter benefit more from enfortumab vedotin, and enfortumab vedotin is also effective treatment for advanced urothelial cancer in the less selected real-world setting also. We have implication for practice that enfortumab vedotin is effective not only in bladder cancer, but also in upper urinary tract tumors. And enfortumab vedotin is more effective in previously treated advanced urothelial cancer patients. And our implication for practice that we should do a mechanistic research to reveal how the identified molecular factors influence enfortumab vedotin sensitivity. This is our manuscript status. We submitted it for the 5th time, and it's still under review now. And now, this is my second project, which is the prognostic and predictive value of tumor mutation burden in immune checkpoint inhibitors treated urothelial cancer patient. A little bit about the background here that, as we know, that immune checkpoint inhibitors are also novel treatment for patients with advanced urothelial cancer from 2016. But the problem here that 25% of patients will benefit only. Because of that, we need further biomarkers to predict the response to this therapy. A TMB as a predictive biomarker, which is mean the number of somatic mutation present in a tumor genome. Our aim here to enhance the understanding of tumor mutation burden as a predictive biomarker and to refine personalized treatment strategies in urothelial cancer therapy. Our clinical question, how tumor mutation burden impact the outcomes of immune checkpoint inhibitors treated advanced urothelial cancer patients? We use the same PECO framework. Our population patient with advanced urothelial cancer treated with immune checkpoint inhibitors, and we are comparing high TMB with the low TMB with the same outcomes as the first project. We hypothesis that TMB provides immune checkpoint inhibitors provide greater benefit to TMB positive advanced urothelial cancer patient. This is our clinical implication that TMB helps select patients for effective ECI treatment, improving care and avoiding ineffective option. We conducted our search key in 3 main databases, and we got more than 7,000 articles, and we are still working in a full text selection. This is our second project progress. To sum up, so I have 2 ongoing interesting and very new therapy. The first one is already submitted. The second one about immune checkpoint inhibitors, and we are investigating the tumor mutation burden, the effect of the predictive value of tumor mutation burden, and we would like to submit it in December 2025. For my additional activities, the main activities that I'm a surgeon, so this is the main activity I'm performing and teaching radical surgery, cystectomy, and radical prostatectomy. And I would like to thank you for your attention by my favorite quote that be brave to stand for what you believe in, even if you stand alone. And thank you.
Congratulations. My question is, enfortumab vedotin, is it available in Hungary? And with which condition and in which settings, which line of therapy?
Thank you very much for your question. I should mention that enfortumab vedotin is really new therapy from 2022. It's got the approval by the FDA firstly, and as quickly as was possible, they approved it by the EMA in 2023 for advanced urethral cancer in a third line as a third line therapy. But recently, at the end of 2024, the enfortumab vedotin got the approval to use it with the combination with the immune checkpoint inhibitors, pembrolizumab, PD1, in a first-line therapy. Regarding your first question, yes, this therapy also they start to use this therapy here in Hungary. As my knowledge, for far only 2 patients we have who got this therapy. The problem is, as everybody knows, here in Hungary, we have to get the permission or individual permission or individual license to get the new therapy. This is very expensive. Thank you very much.
You mentioned that the response to EV is higher in IO pre-treated patients. What would be your expectations? Why is that? Is that because of tumor biology? So are there any factors from the tumor that they will respond to IO and then later on they will respond to the ADC that you presented, or is it patient risk, patient factors, the fitter patients that have a longer time of treatment with the IO and therefore also are fitter for the EV treatment? What did you observe?
Thank you for your question. It's a very interesting question. Yeah, I think there is some of synergistic effect between synergistic effect which could we could say that there is a synergistic effect, like for a patient who got hormone before. If we are speaking about prostate cancer, we know that patient treatment with radiotherapy plus hormone have a higher response rate, and I think also it's true for bladder cancer. We have a synergistic attach, maybe some molecular, and then another things we can say that maybe some. After treatment of immune checkpoint inhibitors, maybe we will have some of neoantigens, which is could be show the tumor cells to this therapy, but it's still unknown what is the reason for that. Because of that, we have to check for a mechanistic research.
And are you aware of any predictive biomarkers, tumor biomarkers for EV response? Because usually you would expect that, right? We have an ADC, so we have an antibody bringing the drug, the cytotoxic agent to the tumor cell.
Yeah,
can you enrich these patients?
We investigated not too much biomarkers, as we can see that FGFR3 alteration have investigated, but we couldn't find significant results here. We could say that a PDL as a biomarker also could be investigated, and the Nectin-4 receptor also. So this is the 3 main biomarkers.
And the second project is a tricky one because you chose TMB, tumor mutational burden. Do you know how TMB is calculated and how the cutoff is evaluated for that?
Yeah, it's a little bit. TMB, the cutoff value is, we can say that higher than 10 mutation per megabase. And lower than 10. This is the high TMB and the low TMB. But in some articles, they used other cutoff. Some of the articles used a higher and lower and intermediate also. For measuring the TMB, there are a lot of sequencing measurement. I think the whole exome sequencing is the most expensive. It's a very expensive measurement, I think. But if we measure by targeted genome, it could be lowering the cost of measuring a TMB.
Exactly, that's exactly the point. TMB is a very heterogeneous biomarker. It depends very much on the technique that you apply, how deep your analyses go, and where you set off the cutoff. So that will be particularly important in the second project, that you really describe very well how TMB is calculated in the respective studies, and then do subgroup analysis based on the techniques that are applied, whether it's a TSO 500 panel or anything else, because the cutoff varies substantially between the techniques.
Yes, thank you.
Any other questions?
So you had some plots where you said you had a statistically significant and clinically relevant effect, and sometimes you had a clinically not relevant effect. How did you determine that?
What I should mention here, that our results should be presented with caution, because we don't have a real control group. And all of those patients in favorable ECOG status and unfavorable ECOG status have a high response rate. But we are investigating the difference between the groups. I can say that we have a 60% objective response rate for all those patients. And we investigated inside the 60% response rate, which patient will benefit more. So because of that, I can say that I can decide which is clinically relevant for us and which is not. We know that there are p-value, which is could say if 0.05 under the 0.05, we could say about something is statistically significant, but is still not clinically relevant, even if it's lower than.
Yes, my question is how do you determine? So if you have like an odds ratio of, I don't know, 0.72 with like whatever confidence interval, how like what's the procedure for saying, oh, this is relevant, this isn't relevant?
The pooled we look at the pooled effect size. It's higher than 1, or you mean, or maybe I don't understand that.
Like the relevancy would like probably be about the magnitude, right? So
yes.
It's like significant because there's a lot of like data, but too small. Then you say that it doesn't matter that it's significant because it's too small. So what's the process for determining what's too small or big enough, or yeah?
Where would be your cutoff? When you have an odds ratio? 72.
Yeah, but.
Is that clinically a huge benefit or a low benefit? It is an odds ratio of 69 different.
Yeah, I think in my project it's very difficult. It's very difficult to have a cutoff because all of those patients have a very high response. So I think it's we could say if we look for the forest plot, then we can decide it's relevant or not, especially if the p-value is under the p0.05, and if the p-value is higher than 1.4, maybe if you would cut off 1.4.
Maybe a question going a bit in the same direction. When we have a clinical trial and we observe the effect, we talk about efficacy. So kind of the pure effect of the drug in a very selected group of patients. When we go to real world, then we talk about effectiveness, where we try to take these benefits to our patients. When you compare the selected or selective cohort in the randomized controlled trials to the real-world patients, what are the differences in patient characteristics any other strategy that you have to keep in mind when applying this drug to your real-world patients with respect to efficacy or effectiveness and also safety side effects of this treatment?
When a patient if I understand, you ask about the patient, which patient characteristics should be included.
So basically, what patients would you select in real world? Would you also select kind of only the very fit patients? Usually in clinical trials, you have ECOG 0 to 1, 0 to 2 is excluded, 3 also. Would you consider this treatment also safe enough for patients with worse ECOG performance status that have more morbidities? And what would be the key side effects that you would counsel the patients when recommending this drug?
Thank you. According our manuscript, we could say that we should give this treatment for subset of patients who benefit according to our meta-analysis. But if you ask in my opinion, I would give the treatment for all the patients because there are no other choice for those patients. So the ORR, the objective response rate, is very high when they are compared it with the chemotherapy and also the overall survival. So yeah, this could be our limitation of our study, that we not compared with other treatment, but in my opinion, I think in my practical, I would give this treatment for all the patient, because we don't have other choice, especially in a third line setting.